you will only find 4.8% of prevalence for facet joint, which means the way how they diagnose the spine problems. If you go to interventional pain physicians, you will find at least 50% and more prevalence. The problem is also you have absence of non-interventional gold standard for diagnosis. Whatever you do non-interventionally, it's very unreliable. And also there is a very poor radiological correlation. So this is about pain medicine. You see the patient with morning stiffness moving around to get better pain in retroflexion. MRI can show facet arthrosis, and you see some patchy distribution to extremities. You can suspect facet joint pain, but it's very unreliable. Evidence: you don't have strong, consistent, positive clinical predictors of facet pain. You have negative predictors of successful block because you can mix it up with radicular pain, discogenic pain, and of course on every single pain patients with back pain, you have to count with psychosocial issues. So what is the gold standard for diagnostic on such a kind of patient? You do the median branch block. This is the picture from a colleague of mine. His name is Juram Laka. So you know all the drill because all of you are pain physicians, so I don't want to bother you with the technique. The only thing I would like to mention is you have to be extremely precise with your median branch blocks. When I'm saying precise, it means you have to place your needle correctly where the median branch is, and then you have to use the correct amount of local anesthetic, not to get false positive, false negative answer, so not to get a distribution into the foramen. The recommended volume of local anesthetic is 0.3 milliliter. What you see with the contrast dye is 0.2 milliliters. So you see that spread is really sufficient with the low amount of local anesthetic. And then, when you make a proper diagnosis, you would like to treat the patient. The golden standard is radiofrequency technique, and for this technique is use anatomical placement under X-ray guidance without direct visualization. So you don't see the nerve if you really ablate it, if you really interrupt the nerve, and also you don't see the whole process of ablation. You only guess at what you're doing. Of course, you can have good clinical results. I'm not saying it's not possible, but you can also do it in a different way. You can use optic vision, and then you come to the endoscopic, either RF denervation, what we started doing before, or you do endoscopic ablation. What is the difference? What we started to do a few years ago, we endoscopically placed our instruments on the median branch, and under direct vision, we interrupted the median branch. What we do nowadays with the different system, we place our instruments on facet joint itself, and then with the high heat and rotational capsular tissue shaving, we're taking away the capsula of the joint. So what you do in 3 steps, you open the joint, you decompress the joint, you flush the joint with the fluid, and finally you use the radiofrequency probe to do the destruction of the terminal nerve endings within the joint itself. You don't go on median branch anymore, which has maybe some advantages. It's a longer lasting effect if you focus on terminal branches. And also, you are maybe not influencing the multifidus muscle with interruption of the median branch. So this is the instrumentation, quite simple. It's very similar. It's part of stenotic endoscopic instrumentation you can use for decompression of the spinal stenosis. And the placement of the instrumentation is on the inferior articular process, to the mid part of the facet joint, somewhere here, to cover the capsula and the joint and the facet joint. This is the cadaver from our lab, so you're placing it here, covering the joint, part of the inferior articular process and part of the superior articular process with the working sleeve. And then technically you can visualize the capsule and surrounding tissue. You can do resection, coagulation to see joint gap and surrounding bone. You finalize the capsulation with reamer if necessary, and then you can do denervation if you want, also at the level of superior articular process and transverse process, but we don't do it anymore. On X-ray, this is step by step. From the lateral view, the working sleeve, and then you will come to the endoscopic view. This is what you will see on your endoscopic screen. In inferior articular process, the facet joint, and superior articular process. If you ask me about evidence-based, for now, there is a study from, it's the most famous study about endoscopic facet debridement from Dr. Scott and his group. They used laser in this study, and they showed quite good results, or very good results, superior results to radio frequency and cryodenervation, lasting longer than 3 years in comparison with radio frequency and cryo lasting plus minus up to 24 months. I will show you just our own initial data. This technique we have been using for plus minus 1 year, and the initial data we have with the 6 months follow-up. What is interesting right now is that there is a statistically significant reduction in pain when we're using quality of life questionnaire and visual analog scale in 3 groups. The group was RF denervation, cryodenervation, and endoscopic ablation. And the plan is to follow 12, 24, and 36 months. Right now, on 6 months interval, there is no difference on radio frequency, cryo, and endoscopic procedure, which maybe means all 3 procedures are good, but the important question is what happens in 3 years' time if endoscopic procedure is superior or not. I can't tell you yet. So what I can say slowly at the end of the presentation, endoscopic facet ablation has maybe some advantages in comparison with radio frequency or cryodenervation. You can see the tissue, you can see the nerve, you can see RF probe, you can see the whole process of your ablation, and you can most probably expect longer effect for the patient. And there is a small thing maybe, but important, there is no multifidus muscle function reduction, which is maybe playing some role for the patient as well, I think. If we go to small disadvantages as well, of course you're increasing cost of your procedure because you need a surgical theater, you need more expensive equipment, you need more people within the surgical theater, and of course you need to be more competent because you have to learn how to work with endoscopic instrumentation. I think that. So thank you very much for your attention. That's my final conclusion, and I would like to show you in sunny Dubai a picture of snowy Slovakia. And this is, you would be surprised, this is team of my doctors. And thank you very much.
Very interesting to see the new technique, and it is, yeah, it is that therefore that we have an innovative pain meeting here. So you are adding really value. I'd like to ask someone in the audience if you have a question.
Thank you very much. Very interesting talk. You didn't tell us, however, about complications, in particular about any instability caused by putting a reamer into the facet joint or any other complications that you have faced.
Are you a pain physician or a spine surgeon?
I am a neurosurgeon.
Neurosurgeon, yeah. Because this is a very traditional question from someone who is doing surgery on spine. Pain physicians never ask this question. I can answer in a very simple way. What you do, you're not destroying the whole joint and the whole capsule. That's not the goal of the procedure. You will get a scarring tissue and sort of re-healing process. And normally, what you qualify for, the indication is not like a virgin, nice, young back. You are doing this procedure on people who are 40 plus with some kind of facet joint degeneration. If I have a untouched facet joint with no arthrosis, nothing like that, I don't qualify the patient for endoscopic procedure. I'll go for cryo or for RF. So I haven't mentioned this. On arthrotic joint, if you do this procedure with just a partial capsulotomy, you will get some scarring tissue, and so far I can say our experience is not showing any change of stability of the segment. We haven't seen any instability caused by the procedure yet. We are trying to do follow-up with MRI as well to answer this question competently. But as I said, our follow-up so far was 6 months. Now we are approaching 1 year follow-up. But what we have seen on all control MRI, no instability caused.
You do it bilaterally?
Yes.
Thank you very much. Dr. Kaplan, do you do a single level or sometimes you prefer multiple level?
My experience is that we always do minimum 2 joints, which means 2 joints is minimum. The common practice is that on testing, you will get at least three levels positive for the procedure. So we do 2-3 procedures. It's very often. Sometimes I think the maximum level we have done is 5 level on 1 session.
Yes.
And also sometimes we do bilateral, but I try to avoid bilateral. I only do it honestly when I have a patient coming from long distance and he has a logistic problem to come back again. And our testing is showing results that bilateral is also an indication. But yeah, definitely more levels, 3 and more.
Thank you. That is very interesting because is this thinking, do you have a kind of theory behind it, or is it just that you do prognostic blocks and that is your basis to do multi-level?
Yeah, we play with diagnosis quite a lot because I was trained by Dr. Sherunat from Sweden or UK, and his strategy is that you test 3 levels. You see if you have a pain relief, 70% or more. If you have 50% or less, you test 2 more levels until you will either get the proper answer or not. So you would like really to play and find the proper diagnostic answer before you decide to go for the procedure. So yeah, we are trying to be as precise as possible on the diagnostic part, and when we get a proper answer, then we go for what we have established in the diagnostic process.
Thank you. Yes, because when we discussed Dr. Heidel, who was not online, so sorry, but I already suggested that a moving segment, there is a lot of misunderstanding. What's a moving segment? Is that one disc and 2 vertebrae, or is it or is it 2 disc and 3 vertebrae? It's a kind of, they call it the encephality model. And I think the tendency is that you have to think about not a one level. Let's say if you do the surgical procedures of one level, or you do fusion on one level, the results mainly are very poor. So I think it should be multi-level. Thank you for your comment.
Okay, yeah, if I
Any other question? Sorry, you want to comment?
I just wanted to say that the common practice in many clinics I've seen that you only test low 3 segments, and if it's negative, you say it's not a facet joint pain. Very few people go higher up. You need to go higher up as well. Because sometimes it's D12, L1, L2, L2, L3 level, or sometimes it's a thoracic level, sometimes it's a cervical level. Yeah. Sometimes it's a combination.
Thank you, Dr. Robert, for this nice talk, a new technique for facet joint innervation. The bottom of the research, the pain knowledge is at the heart of this revolution, definitely. So, by the way, I'm going to ask you about the benefit of this procedure, for this technique, for elderly versus younger people. If you know that in the past, we even ask about training not to inject the facet joint itself because we may damage the capsule itself. We prefer to denervate the medial branch for this. Now, the technique, I think it is going deep in the capsule itself. So, what is the benefit? For the elderly, definitely I agree, it is always damage this capsule. So, but for the youngers, what about the outcome of this technique?
I can answer according to my experience, so it's not going to be evidence-based, but anecdotal or experience-based answer. What I see, as I mentioned before, I don't do this procedure on young people so far because I think it's not a good idea to go and damage the facet joint, which is not showing any symptoms, any signs of degeneration on MRI. Of course, you can have a facet joint pain on such a kind of spine, but in that case, I'd rather go for regeneration therapy or cryo and some physio concept instead of radical procedure. This is for someone who already has some kind of damaged facet joint. So you see a degeneration of the joint, and on those people, what is interesting in comparison with the denervation procedure, which is sort of a palliative procedure, you don't improve the quality of the joint and you don't improve the mobility of the patient. If you perform endoscopic ablation, you take away the inflammation from the joint and you decompress the joint. And finally, the quality of the joint, despite it doesn't look like that on MRI, is better, and the movement, the mobility of the patient is improving as well. That's what we see on our patients so far. So advantage on arthrotic patients with facet joint arthrosis is that they are improving mobility as well, not just pain relief. That's one answer. And you asked about intra-articular block as well. We still use median branch to make a diagnosis. We don't do intra-articular blocks, but I'm not saying it's a stupid idea to do intra-articular block to establish the diagnosis for intra-articular procedure. Maybe it makes sense, but we haven't moved to this stage yet.
Thank you. One other question related also to the facet joint denervation. So in pain management, always we are going for the simple way of relieving pain for a long time. This is our idea. So nowadays we have very good evidence about cryoablation for facet denervation because of the size of the lesion on this side. So if do you have any differences between cryoablation versus your technique?
Yeah. What I presented was comparison of RF, cryo, and endoscopic after 6 months. And what I've said was there is no difference between cryo, RF, and endoscopy after 6 months. And what I expect after 3 years follow-up, endoscopy will last longer than cryo because of physics of the procedure. Yeah? Here you are aiming on terminal nerve endings with a high temperature. With cryo, you use low temperature, and the regeneration of the median branch is happening after 6 months, plus minus. So I expect cryo is definitely shorter lasting procedure. But it's good in young people where you need regeneration and improving the mobility in a different way with exercise.
Thank you very much, Robert Kaplan. Now I think we are very nice.